Welcome to my YouTube channel. Today we're going to talk about cholesteatoma. Cholesteatoma. So we are going to begin the definition of cholesteatoma, but let's look at the name first. From the name, it's chole and atoma. If you would interpret even without reading or knowing the name, you will know that this may be it's something from cholesterol or maybe it's a tumor. But this is a misnomer, meaning this is has nothing to do with cholesterol, has nothing to do with cancer. So cholesteatoma is an abnormal non-cancerous growth of keratinizing squamous epithelium in the middle ear and or mastoid process. So it's a special form of chronic otitis media. So as I've mentioned before, you have presence of abnormal epithelia in the middle ear or the mastoid. And this abnormal epithelium usually trigger the inflammatory response. So the types of cholesteatoma, they are kind of classified into congenital and acquired and primary and secondary. So congenital cholesteatoma, this is present at birth and arises without prior infection or trauma. Whereas acquired cholesteatoma can be a form of chronic otitis media, so meaning you have had an infection previously or maybe trauma. So in addition to that, we also another have classification where we have primary and secondary. So primary is caused when you have chronic eustachian tube dysfunction leading to traction of pockets. Whereas secondary, this is occurs due to trauma, surgery, and recurrent infection. So let's look at the pathophysiology. And before we look at the pathophysiology, we look at the risk factors. So the risk factors of cholesteatoma include chronic otitis media, recurrent ear infection, eustachian tube dysfunction, trauma, or surgery. So the pathophysiology behind it, as I said, you're going to have eustachian tube dysfunction, and this will lead to the negative pressure in the middle ear. This therefore will lead to the retraction of the tympanic membrane, and this retraction will lead to epithelial entrapment and failure of migration. And if it fails to migrate, then you will have keratin debris accumulation. This keratin debris accumulation then will lead to chronic inflammation and enzymic activity, and therefore leading to bone destruction. In addition to that, it will also be a site for infection, and you can have superinfection and chronic otorrhea. And a significant distinct feature of cholesteatoma is foul smelling ear discharge and further complications. Clinical features, we are going to begin with the symptoms. And the symptoms, this is something I've mentioned before, and you're going to have persistent foul smelling otorrhea discharge. So a patient comes in with foul smelling otorrhea or discharge, that is the first thing you think about. Next is conductive hearing loss, fullness or pressure in the ear, tinnitus, that is the ringing of the ear. In advanced cases, you can feel vertigo, you can have vertical or facial nerve palsy. So what are you going to see in terms of signs, or when you have examined the patient, you're going to see retraction pockets in the tympanic membrane, as you can see in the above image. If you remember the pathophysiology that you have talked about, you can see granulation tissue as is seen in this image in the middle ear. You can also see perforated eardrum, and the reason behind this is because it's a kind of sequelae of chronic otitis media. And in chronic otitis media, you usually have perforated eardrum. Next, you can also have ocular erosion on imaging. So the diagnosis of this patient, obviously, they'll come in, you'll have to do history and examination, and they'll come in with what? They'll come in with an history of foul smell discharge, an history of previous recurrent infection, and history of trauma, and all those risk factors, you have to rule them out. In addition to the examination, you have to see, is the eardrum perforated? How is the eardrum? How is the tympanic membrane? Can we see granulation tissue on otoscopy? So assess for persistent discharge, hearing loss, tympanic membrane abnormalities. In imaging, you can do a CT scan, that is of temporal bone, showing bone destruction. As we said, it's going to have enzymic activity that is going to cause bony dysfunction, erosion of the ossicle, and the extent of the disease. MRI for complications like extracranial extension and abscess formation. Auditomy, this is to access the hearing loss, to confirm conductive hearing loss, and otoscopy, which is part of the examination. This is to identify retraction pockets and granulation tissue. So management, you're going to begin with non-surgical, and because we said one of the risk factors is chronic otitis media, therefore you're going to treat that infection. So the infection control, and chronic otitis media is caused by Pseudomonas aeruginosa and Staph aureus. So the drug of choice that we used in chronic otitis media is mostly chloroquinolones. So you can give ciprofloxacin eardrops. In addition to that, you can also do regular cleaning, and this should be done by an ENT specialist. Next is surgical treatment or management, where you can do tympanoplasty, and this is the repair of the tympanic membrane. In addition to that, you can do mastoidectomy, and this is the removal of the cholesteatoma, that is the granulation tissue, and the infected mastoid air cells. In addition to that, you can do ocular reconstruction, for restoring hearing. And prognosis of this disease is good with early diagnosis and appropriate management, and recurrent is possible. So you ensure the patient comes in for regular follow-up. It's very essential. So in the complications, we have divided them into a systematic manner, where we have intertemporal, intracranial, and others. And intertemporal, we are going to have hearing loss, and you already said most commonly is usually conductive. However, you can have sensorineural. Ramphitis in the infection of the ramphis, and this patient is going to present with vertigo. You can also have facial nerve paralysis, and intracranial mostly is due to the infection. So you are going to have meningitis, that is the infection of the meninges. You are going to have the triad of meningism, which includes, you can write in the comment section, brain abscesses and sigmoid sinus thrombolysis. In addition to that, you're also going to have mastoiditis. Thank you.